All right, and speaking of readmissions, we have another amazing poster. All right, it is our staffing ratios contributing to 30-day hospital day readmission in med-surg units. We have Lior, Appel-Kraut, and Peter Coe. Thank you.
Hello, my name is Peter. So our project was very interested in staffing ratios and how that contributed to 30-day readmission rates. So our question was, in adult patients admitted to the medical surgical units in hospitals within the United States, how do fixed nurse-to-patient staffing ratios compare to variable nurse-to-patient staffing ratios, and how does that affect 30-day readmission? So we just need to define some we need to have some definitions first. So a 30-day readmission is a metric that was created by the Hospital Readmission Reduction Program under the Affordable Care Act. It was made public in 2009, and then fees based on that were implemented in 2012. And they track 6 different diagnoses. It's acute MIs, pneumonia, heart failure, CABG surgeries, total knee and hip replacements, and COPD. So the CMS calculates the expected readmission based on the individual hospital, and they do a risk adjustment based on the patient population, the ages, genders, the various comorbidities, and if the hospital has a higher than expected readmission, they're fined up to 3% of their Medicare revenue. So for our study, the literature review, we actually found studies that were focused on pneumonia, general surgery, total knee and hip replacements, pediatrics, heart failure, and COVID-19. And most of them looked at the Medicare population, which is 65 and older, because this is a Medicare metric. And all of the studies we found pointed to that staffing ratios had a direct correlation to increase in 30-day readmission rates.
So we did expect to find this correlation, but I would say the correlation was stronger overall than what we maybe thought it would be going in. So in the bottom left, you can see a chart from one of the studies we looked at that was looking at Medicare patients with total knee and hip replacement. And this study found that for each additional patient a nurse was in charge of, that patient was 8% more likely to be readmitted within 30 days. So that's a really significant impact on the patient, on the hospitals, on the nursing staff, all around. So then we looked at the country overall to see where is there legislation mandating certain staffing ratios. And you can see in green that the only state in the United States that has mandated staffing ratios for all units is California. There are 3 more states, New York included, that has legislation for some units, right? So in New York, that's for critical care patients at a legislative level so that no hospital and no patient can fall through the cracks. And then on the map, you can see some of the other ways that states have put in place legislation for staffing ratios, like a staffing committee that might need to have a certain percentage of nurses on it that can give input, but does not necessarily lead to staffing ratios, or a public reporting system so that they need to let the public know what their ratios are. So based on what we found, our major recommendation is modeled after California's legislation that there should be staffing ratios in every unit, and that's what you can see in the bottom right. And we did find that a major limitation of our study was that it is largely based on Medicare and Medicaid data because that's who's reporting their ratios and also reporting their readmission rates. And so we'd like to look at a larger group of patients, different populations, and see if this still holds. But overall, we're recommending that, legislatively, there are staffing ratios in all units.
And if anyone was interested in the number, so for each readmission, it costs Medicare about $16,000 per patient. In 2019, we had an excess of $26 billion in spending because of readmissions, and they found that $17 billion of that could have been avoided. And then for the average readmissions across the United States, about 14.6%, New York is a little higher at 16%, and California, the only state with legislation, is actually lower at 14.5%. And another interesting fact is California has a target of 11.9% for readmissions, and New York doesn't have a goal. So.
And then the last thing I'll add, and then we'll take questions, is part of what drew us to this is that we knew there are critical care legislative ratios. Our entire group who's here today, thank you for coming, we were all together on a med-surg unit for our first clinical rotation here at Downstate. And so we wanted to look together at what does this look like, not in critical care, but in med-surg, where we're doing our clinical rotations.
Thank you.
We got a question?
Hi, thanks for this interesting and exciting presentation. Why do you think California, it's only 14%? I would think it would be so much lower. Any thoughts?
As in, lower as in the number of remissions?
I don't know, but I will say, for example, looking at this study, the range of readmission, so it changes quite significantly between each patient, but the range is not that large. Like in this study, it was between 5.64% and 7.67%. So when you're looking at a large-scale population, that is a lot of patients, it's a lot of money, it's a lot of time, but it's not maybe lowering it 10 percentage points. And a question would be to look at we looked at 30-day hospital readmission, right? But you could look at other patient outcomes.
Right. Thank you.
Any other questions? This one had us talking. Your poster had us talking. So thank you both so much. Good? All right, excellent. Thank you. Good job.